Good morning, everybody. As is our tradition, I'm going to jump in and make a few comments, and then I'll introduce Chris Pittenger, who will be our MC for today's festivities. And as I say every year, because it's true every year, the Lustman Awards are probably my favorite day of the year. And you think about the thought that comes to mind is, how do these young people get to be so smart and accomplished at such an early stage of their careers? And I think the answer is pretty obvious, which is that we're extremely fortunate to be able to recruit such incredibly talented young people, and that we try very hard to give them all the opportunities that we can to realize their own personal dreams for what their careers might be like. We try to support them in every way we can, and then get out of their way so that they can accomplish what they set out to do as much as possible. So we're just so thrilled and so proud of the young folks that you're going to hear today, but all of the residents, everybody who submitted materials for the Lustman Award. They're just really incredible, and it's not surprising that they are going to be the next generation of leaders in the field of psychiatry. I also want to add my own 2 cents before Dr. Pittenger elaborates more about why the connection to the Lustman family is so important, and we really appreciate Representatives Lustman, John and Susan, and to be here today to be a part of this, and of course Jeffrey, who was very active in our department for many years. The other thing I wanted to do today was to just let you know a little bit about the upcoming schedule. So. Next week is the State of the Department address, and every year, it used to be, every year after the State of the Department address, we would take a department picture. And we accumulated a closet full of pictures. There were just too many pictures to put on the wall. So we thought we would take a picture every 10 years. And it turns out that this is the 10-year, time for the 10-year picture. So I invite all of you to be a part of the department picture, which we'll do immediately after the State of Department address. And please let everybody know that we're taking the picture next week, so we get really show in the picture who we are. And when we look back on these pictures, who we were. And if you're like me, you might find that you can find yourself in several different pictures, and it's kind of cute to track our departmental history. And then the following week is graduation, and resident graduation is going to be on Thursday night, the 13th, at the Lawn Club at 6 o'clock. And then Friday, in Grand Rounds, we will have the graduation speaker, who is Alpha Stewart, who is the president of the, or past, now immediate past president of the American Psychiatric Association. And that should be a wonderful, wonderful address as well. So, what a great month, it is, beginning with the Lustman Awards. I'll include it in June. The State of the Department, the graduation address. It's really great to be a part of this community, to have such nice things to do. So without further ado, oh, and there's one other thing I wanted to mention, which is that all of you probably know that we have been engaged in a very long and drawn-out discussion with the state legislature after the governor proposed to eliminate more than $1 million from the CMHC budget. And we've worked very closely with the New Haven delegation and leaders in the legislature to help them to understand the impact that these cuts would have, testifying and doing other things. And so you'll be pleased to know that the cuts were removed from the budget. And once again, we'll live to see another day. And I expect we'll be back in the same place next year. But it just shows that if you believe in the mission and you stick with it, you can make a compelling case for continuing the work you do. So at this point, let me introduce Chris Pittenger to more formally introduce the festivities.
Thank you, John, and thank you all for coming to this really great event. I agree with John that this is one of my favorite events of the year because it's a celebration of great science, but also of our trainees and of a vision of where psychiatry is going, how we are going to help bring it in to the future, and sort of brings all of these exciting things, well, and of our community and of our mentors, who you'll hear from briefly. So it brings a lot of the wonderful things about our community together in a single day, and that's really great. Just to echo what John said, I want to thank the Lustman family who are here and the board of the Lustman Foundation, who've made a commitment over 47 years, to maintain this award and recommitted some years ago with to formalize it a little bit, and that it really has become a mainstay of the department and of our research educational program. To say a few more words about Seymour Lustman, who was an extraordinary man. He was here at Yale from 1955 until his death. But after serving in the Army in World War II, he received his PhD from the University of Chicago and his MD from the University of Illinois, and then he came here for his child fellowship. Both adult, for his residency and his child fellowship in 1955, and joined the faculty in 1962. And was promoted to the rank of full professor in 1964, which I find a little alarming, if you do the math. So he was interested from an early time about the interplay between nature and nurture, which are concepts that we hope that we have largely transcended in the modern era. But back in the 50s and 60s, this was really a central in the cutting edge of thinking about human development, human psychological development, and psychopathology. And he was known as an extraordinarily innovative and thoughtful scientist. John just told me a story that I think illustrates that, which was early in Dr. Lustman's career. The polio vaccine came on board, and polio was greatly reduced as a scourge on the children of this country, and they had all of these iron lungs around, and Lustman said, well, this is a wasted resource. We got these machines. What can we use them for? He turned them into little infant laboratory settings. We have a completely controlled environment in which you can observe an infant engaged in various behaviors in a controlled setting, which is a brilliant way of repurposing, I guess you said, swords into plowshares, repurposing something that was a way of dealing with a scourge and turning it into an opportunity for new knowledge and advancement, which I find really exciting. The Lustman Award has been given by the department since 1973. So yeah, that makes this its 47th year, which is a remarkable tradition. And the recipients of this award, so it goes to residents or fellows in psychiatry who given for research that they've done during their training. And the awardees, going back all the way to 1973, are listed in a plaque just outside the auditorium here. And if you look down it, it's an extraordinary list. many of the leaders of our field have been recipients of this award. That speaks, of course, to the generativity of this department as a place that has spawned leadership across the country and across the world. But if you look out there, there are deans, there are department chairs, there are leaders of industry, and at the NIMH, there's a couple journal editors on that plaque, I think. So it's really an impressive list. And so you guys are joining illustrious company, and you should feel proud, and you should feel high expectations. As I said at the beginning, another thing that's wonderful about this award is it's a chance to celebrate our community, and in particular our mentors. And so as we move on to the presentation of the awards and to the talks, we're going to invite the mentors of our awardees up to give brief introductions. And I think that we need, while we're celebrating the awardees and their work and their accomplishments, we're also celebrating their mentors, because none of this happens in a vacuum. It happens with dedicated support from the community as a whole and from the mentors in particular. And so we take pleasure in the opportunity to acknowledge the mentors of our awardees today. And our three awardees, who you'll meet in a moment, I think the last thing I want to say is I really love this particular set of awardees because of their scientific and intellectual diversity. I think that they celebrate how our community is doing cutting-edge, really exciting work and training the leaders of tomorrow in multiple different areas. We have basic lab science and quantitative computational modeling to try to understand our disorders at a theoretical level. We have public health and how to try to help people in the community, and we have development of novel treatments in clinical research. So an enormous breadth of accomplishments, equally impressive across the board. So I guess that's all I have to say, which is probably more than enough. I will invite Michael Block up to introduce our first awardee and our first speaker, Jenny Dwyer. Michael is well known to all of us. He was a graduate of the first class of the Solnit integrated program between the adult and child department. And so his tenure here, I think, has both encapsulated and celebrated a new synergy and alliance between the training programs in the two departments as we've worked together more and more closely. And I've seen Michael's career grow over the last 2 decades. It's a pleasure to see him now some years now, stepping forward as a mentor in his own right. Michael.
Thank you. So I get the pleasure of introducing Jenny Dwyer for me and Jerry Sanacora, who unfortunately couldn't be here, who's her co-mentor also. And I guess just like Chris said, Jenny Dwyer is a soon-to-be graduate of the Albert J. Solnit training program in child and adult psychiatry research. She got her PhD in developmental neuropsychopharmacology from UC Irvine, the Anteaters. I guess she's won a variety of awards, which I'm not going to get into all the awards, except she's gotten funding from the Klingenstein Foundation and the Thrasher Foundation to do this research. I guess the thing I'll talk about is actually probably something you don't know about her or this project, and that I think is really important and probably worth mentioning here, especially since this ceremony takes place at CMHC, was that she actually got the idea for the project and doing this study of treatment refractory depression in kids while working as a second-year resident on the CNRU. So she actually saw some of Jerry's work, I forget whether it was ketamine or S-ketamine, and seeing the dramatic effects it had on adult treatment refractory patients with depression. And then essentially the research really bore out of the question, like, why aren't we doing it in adolescents? Adolescent suicide and depression is a serious problem. And I think sort of the research program came off of that. And I think as a mentor, I hopefully did a good job. I didn't get the pleasure of recruiting her. That was actually Hannah Stevens, another former Lustman Award winner, but hopefully I was able to encourage her and stay out of the way of her ideas for long enough so that she was successful. And I think that's really, I feel like I owe a lot personally to her, because a lot of my research has come out of some of the program of research she really had the vision of developing. I guess the other thing to say is just the CNRU has been really important in the sort of the research career of many Solnits who've come through the program. So like Jerome Taylor, who recently got his K Award from the University of Pennsylvania, did a lot of work with ketamine on the CNRU, and then also worked a lot with Vinod in the STEP clinic. And then obviously me, I was looking at my top 10 cited papers, as I happen to do in the morning some of the time, but six out of the 10 of my most cited papers are actually really done in collaboration with other people who were on the CNRU, and only half of those were done with Chris. So a few were done with Jonas, and one was done with Vlad way back when. But it's a long tradition of really strong collaboration between the departments, which really even goes back to Seymour Lustman, who was the director of research at the Child Study Center, and worked with Al Solnit on a lot of his most famous work. So he worked with on the best interests of the child, and I guess he did that with other people like Al Solnit. Other people were like Anna Freud and Hillary Clinton were involved in that project. And that's just to say that how beneficial that's been, the collaboration between the two departments, and that Jenny's a great example of that. And then I'm sure she will be on the plaque, and at some point everyone will be singing the praises of her accomplishments.
Okay, thank you, Michael, for that introduction. I'm really excited that I'm able to talk to you guys today about the work that I've done with Michael and Jerry during residency, looking at ketamine as a novel therapy for adolescent treatment-resistant depression. So I have no relevant conflicts of interest to disclose, so I'll jump right in. So adolescent depression is a significant health problem. So nearly 1 in 5 adolescents will experience major depressive disorder. Suicide is now the second leading cause of death in this age group. The TADS trial showed us that 40% of adolescents with MDD failed to respond to their initial treatment with an SSRI, with Prozac in that case. And then the Tordia trial followed up on that, showing that of that SSRI-resistant population, nearly half remained depressed even if you switch meds and add psychotherapy. So this tells me that we need better treatment options. And a few moments just to talk about sort of some sobering facts about suicide. So these are data from the CDC looking at high schoolers, so 9th to 12th grade, that 17% have considered attempting suicide in the last year. 14% have had a suicide plan in the last year. 8% have actually attempted suicide in some way, shape, or form, and 3% have made an attempt that required medical attention. The suicide death rate is 13 per 100,000 among adolescents, and so the absolute number for that is 5,500 deaths per year. And to sort of put that in perspective, I was looking at Hamden High School. This is right up the road from my house. A lot of my patients go there, and that's about 1,100 students. And so this is about the equivalent of losing 5 Hamden High Schools a year to suicide, which is totally unacceptable. So I'm going to talk about ketamine, and I know this is a very sophisticated ketamine crowd. So you know that ketamine is a medication that's traditionally categorized as a dissociative anesthetic. It's a non-competitive NMDA receptor antagonist. It's been used in anesthesia, including pediatric anesthesia, at these higher doses, and then in psychiatry at this lower dose of 0.5 milligrams per kilogram over 40 minutes. I'll talk very briefly about a couple of the main findings of ketamine in adults. So this is the Berman paper, the seminal work that John Crystal and Dennis Charney did here. And this is showing that ketamine rapidly reduces depressive symptoms. So here, 24, 48, 72 hours. And that's a far cry from our traditional antidepressants, where the x-axis would extend, all the way down the wall, looking at 4 weeks, 6 weeks, 8 weeks to get a response. This inset is just showing that the side effect profile is distinct from the efficacy profile. A second point that I'll bring up is this idea that ketamine is also anti-suicidal in adults, even after you control for its antidepressant effects. So this is some data. I think actually Sam presented this for the Lustman Awards a couple of years ago, and went on to publish this work in AJP. And so you can see here the ketamine-treated people in the green have a significant reduction in suicidality compared to the controls in orange. And I think this is particularly relevant for those of us that are child psychiatrists, where we're faced with the black box warning, a controversial warning still, but this idea that a medicine that's supposed to treat depression could actually provoke suicidal thinking, which is really the feared consequence of untreated or undertreated depression. That idea is very unnerving, both to families and to doctors. And so to have a compound that's both an antidepressant and distinctly anti-suicidal is very appealing. I'll say a brief word about mechanism, and this is summarizing a lot of, again, the seminal work that's been done here in Ron Duman's lab and others. This idea that ketamine enhances glutamatergic signaling and promotes synaptic plasticity. Summarizing here that key sites of action are thought to be prefrontal cortex and hippocampus. And hypothesized mechanisms include this idea of NMDA antagonism on inhibitory GABAergic cells, which facilitates glutamate signaling. And also, I think, not a mutually exclusive idea that there are ketamine metabolites that may also directly stimulate glutamate receptors. And if you're interested in this kind of stuff, a shameless NNCI plug that we have a cool lecture on this called SAD Synapses, if you want to hear about it a little bit more. So what do we know about pediatric psychopharmacology of these systems? So these are systems, the glutamate and the GABA systems, are ones that continue to develop during adolescence, particularly in prefrontal regions. So there's active pruning of glutamatergic synapses. Animal studies suggest that there's changing relative profiles of GABAergic interneurons, and animal studies also suggest that there's key changes in the receptor subunit compositions of both NMDA receptors and GABA-A receptors. So it is a very dynamic and complicated system. And I think, we need to be careful not to assume that just because medications work in adults, that they work to the same extent or maybe even in the same way in the developing brain. Another thing that gives us cause is this idea that animal studies suggest that there's a higher risk for neurotoxic effects of high doses of ketamine in younger animals. So there are things that make us cautious. There's also things that encourage us to push forward. So there's preclinical data suggesting that ketamine reverses depressive phenotypes in adolescent rats. And then in terms of acute safety, ketamine's been used as a pediatric anesthetic for many years. So if your kid breaks their arm and goes to the ER, they're probably getting ketamine. So it actually has an excellent safety profile in the acute setting. Okay, so we decided to ask the question of whether a single dose of ketamine was safe and effective in adolescents with treatment-resistant depression. We called this the KIDS trial. And this was funded by a pilot award from Child Study Center, an ACAP pilot award, and an early career award from the Thrasher Research Fund. So I'll tell you about the subjects in our study. So we were looking for adolescents. We were looking for depressed adolescents. We were looking for significantly depressed adolescents, so a children's depression rating score of over 40. We were looking for treatment resistance, and so here we defined that as having failed at least one prior antidepressant trial, defined as an 8-week trial with at least 4 weeks of stable dosing, although as I'll show you in a few slides, the bulk of our sample had failed multiple treatments. And then this is an add-on trial, so we had our patients stay on their psychiatric meds for the month prior to enrollment and then during the 4-week trial, and to continue in any ongoing psychotherapy. So who do we not include in this trial? So this was an outpatient study. So we excluded active or imminent suicidal ideation or risk and excluded inpatients here. We also excluded folks that had a history of psychotic disorder, manic episode, intellectual disability, or autism spectrum, substance dependence, pregnancy or lactation, and then anyone that was unable to provide informed consent. And then just a quick note about controls and blinding. So placebo rates are quite high in depression trials in general, but they're really high in pediatrics in particular. And we thought it was very important to have a control to really demonstrate efficacy of ketamine above and beyond that of placebo. There's a question in the field about what is the appropriate control for ketamine given its dissociative side effects. The choices these days are saline or midazolam as an active control. And so we went with midazolam in this particular study. And then additional measures that we took to protect the blind included having separate safety and efficacy raters. So if you were supervising the infusion, you were not doing the efficacy ratings thereafter. Okay, I'm going to tell you about the design. So this was a randomized Midazolam-Controlled crossover trial. You can see it's a 4-week trial, 28 days. Infusion days were day 0 and day 14. We can kind of zoom in on the infusion day. So participants received either ketamine at this 0.5 milligram per kilogram over 40-minute dose, or midazolam at 0.045 milligrams per kilogram over 40 minutes. We looked at side effect profiles at 1, 2, and 3 hours. And then we also collected blood to do pharmacokinetic studies to look at ketamine metabolism in this age group. As you might imagine, we talked to these kids a lot in the intervening period, so we did rating scales at all of these days. And then a subset of kids also underwent some functional neuroimaging. And the primary outcome for this study was the MADRS at day 1 following treatment. In terms of our subject recruitment, we assessed 26 kids, 19 consented for the trial. 17 received the first infusion, so 1 left after an undisclosed medical condition was revealed, and another sort of panicked right as we were turning on the infusion pump and decided that they would prefer to withdraw. So subjects were randomized by the Investigational Drug Service here at Yale. So 11 were randomized to receive midazolam and then ketamine, and 6 were randomized to receive ketamine and then midazolam. Of the folks on the left, all of those completed and received infusion 2. And of the group on the right, we had 1 participant who substantially improved after the first infusion, which ended up being ketamine, and decided to withdraw to receive ketamine in the community. This is showing some of the characteristics of our sample. So you can see that we had a heavily female sample, 72%. Which is consistent with the gender difference in depression incidence that emerges following puberty. The average age was 15.4 years, and then here's a histogram just showing the actual number of participants in each age group. And you can see that there's a nice distribution across the age range. About half were local to Connecticut. The baseline CDRS was 64 and baseline MADRS of 33, so a pretty depressed group. The average age of depression onset of 13 years, and this duration of current episode, 13 months. I mean, that is a very long time to be depressed, even as an adult, but particularly, I think, as an adolescent. And I think that speaks to a certain degree of chronicity in this sample. This is showing the average number of failed medication trials, so 4.5 medication trials. So again, even though our criteria was to have failed at least 1, the vast majority had failed at least 2, and some many more. About half had a history of a suicide attempt, and half with a history of non-suicidal self-injury. And as you'll remember, this is ketamine on top of current medication, and so the bottom box is showing the medicines that kids were taking during the trial. So about half were on an SSRI, 40% on another non-SSRI antidepressant, a quarter on antipsychotic augmentation, 1 person on lithium, and a few folks on other mood stabilizers. Okay, so let's look at the data. So this is the primary outcome. So this is showing that ketamine decreases depression scores at 1 day following infusion. So you can see the midazolam treatment in the gray and the ketamine in the red. And this is an effect size of 0.75. As part of our secondary analysis, we did a time course. So this is showing the time course data. Again, you can see this separation at day 1. You can see that the midazolam group on average improves and then sort of comes back to their baseline, and we have a significant separation between ketamine and midazolam all the way out to 2 weeks, which was the longest period that we looked for this trial. This is looking at side effect profiles. So our participants tolerated the infusions very well, but I think this slide demonstrates that midazolam is not an ideal control. So you can see that there's a significant difference in dissociative side effects between ketamine and midazolam, but that these sort of rapidly fall off by the second assessment period. This is just showing some of the most prominent intra-infusion side effects comparing ketamine to midazolam in this group. And I've highlighted the areas of overlap. So for example, feeling like you've spaced out is something that a lot of people feel on both medicines. This idea of being disconnected from your body, although to a greater extent in the ketamine group. But again, the true sort of dissociative symptoms are pretty unique here to ketamine. So 88% of our sample feeling like they're in a dream, those sorts of things. So the conclusions and the future directions here. So I think I'm encouraged by the fact that ketamine was well tolerated in this group. And also encouraged that it significantly improved depressive symptoms at 1 day post-infusion and really all the way out at the group average level to 2 weeks. Although as we sort of informally followed these kids, all of our participants did eventually relapse. So I think this preliminary data suggests that ketamine may be effective and safe in the short term, but like adults, the effects of a single dose appear to be ephemeral. And so there's lots of work to do. I'll talk about a couple future directions. So one, sort of in the clinical realm, is how do we extend the duration of antidepressant action and better understand the maintenance requirements? And as soon as we're talking about repeat dosing, we're thinking very carefully about safety. So what is the safety of repeated dosing, particularly in this neurodevelopmental context? So I recently received some funding from the Klingenstein Foundation to do a repeat dosing study that hopefully will be starting in the next couple of weeks. And then also I think, from more of the developmental science perspective, can we use ketamine as a probe to better understand the pathophysiology of adolescent MDD? So I'm actually going to stop with the science there because I have a couple of thank yous. This is actually very special for me to receive this award as I'm finishing this very long training program. So there's a few people to thank, particularly the Lustman Memorial Fund and the Lustman family. It is such an honor to receive this award. Also thanking our patients and their families. This is an amazing population to work with. I feel like everybody should go into child psychiatry, but it's really a privilege to be led into these people's lives. I'd also like to thank the people that have funded my work, so the Pilot Award, ACAP, Thrasher, Klingenstein, and the T32 at the Child Study Center. I'd like to thank the Block Lab for all of their help in actually implementing this trial. This is like my favorite picture of Michael because I feel like it accurately conveys some personality traits. And while he has a sort of oppositional veneer, underneath it all, he's a very caring person. I think patients and trainees really matter to him, and it's clear that, he puts their interests, I think, above his own sometimes, and that's a generosity that is uncommon, perhaps. So I really appreciate your mentorship. And similar with Jerry, Jerry's like the consummate physician scientist. He's so accomplished in basic science and translational science and clinical trials, and is an excellent physician, and despite being good at all those things, is still incredibly approachable and selfless, and they're just an amazing team, so I feel very lucky to have been working with them over the last 4 years. Thanking also my clinical mentors, people like Bob King and Janet Madigan and Dick Kravitz, really sort of emphasizing the importance of careful listening, both from a diagnostic perspective, but also the therapeutic benefits of that. My educational mentors, particularly Dave Ross, he sort of let me get in on the ground floor of NNCI, which helped refine my teaching, which I really like to do, but also giving this national and probably now international platform, which is pretty amazing. Also the Solent Integrated Program, it's such a unique program. There's reasons why other institutions don't have programs like this. They're very difficult to put together and to fund. So the vision of people like Jim Lechman, Andreas Martin, Dorothy Stubbe, Michael, and Hannah Stevens, also the NRTP, I feel very close to that program and appreciate all of the mentorship from Bob and Chris. And then maybe even more importantly than the administrative pieces of those programs are my colleagues. So I have really amazing colleagues in these programs, and I think it just proves that Yale recruits really interesting, smart, friendly people, and that makes it nice to come to work. And then finally, I just want to thank my family. I found all these old photos, and all the ones that are just me, I'm smiling very brightly, and all the ones with my brother, I have this side-eye thing going on. But I eventually learned how to share, and he gained a few inches on me, so things are good now. But but they're just a really loving, supportive foundation, and that's such an advantage, I think, going into life. And then this guy, my hubby Sean, we've been together for such a long time. He was with me when I decided I wanted to become a neuroscientist and stuck it out through med school and grad school, advancements, dissertation, residency. These are long training programs, and they're long for us, but they're also very long for the people in our lives. So I very much appreciate all of your support. And I think I will stop there, and if there's time for questions, I'm happy to take them. Sure.
Thank you.
I'm an anesthesiologist, and you point out the clinical safety
Mm-hmm.
of the anesthetic use and those doses, and indeed it provides cardiovascular respiratory stability. It didn't continue to get universal acceptance because of the psychological side effects. And you talked about some of the dissociative effects. And I don't have any sense of the literature on this, unfortunately, but anecdotally, we would get reports of people having these disturbing dissociative experiences and then flashbacks during a subsequent period. And so as a result, we use it, personally would use it sometimes and then not use it for periods of time. And I wonder if you have any thoughts on that or any experience.
Yeah, so we consulted with the Pediatric anesthesiology group here as we were designing the study, and they do these surveys after they do conscious sedations or any treatments, and they really didn't have any reports of sustained distressing phenomenon. I think they had one or two people that said that they kind of had weird dreams the next night, but at least in the hands of the group here, that hasn't been a big issue. And then in the trial, we're using this sort of low dose here, but our participants tolerated it very well, and even the ones that had significant dissociative symptoms, there wasn't a lot of dysphoric reaction or fear.
In the interest of staying on schedule, because we have some more wonderful science here, thank you, Jenny. That was a fabulous talk. Wait, stop.
Oh, okay, I was going to run away.
So here we have, it's my pleasure to present you with the first place award for the Lustman 2019. Congratulations and well done. She keeps trying to run away.
I know, I'm shy.
Semi-pro photography.
Okay, thanks.
All right. Yike. Is the other one here? Excellent. Where is it?
I know, those darn MacBooks. Here, just click on that right there.
There it is. Thank you.
Perfect.
Great. Thank you. That was a wonderful first talk. For our next presentation from Al K, it's my pleasure to invite up his mentor, Alex Kwan. Alex joined the department about 6 years ago in the Rybakov research facilities and has set up a really exciting research program using cutting-edge tools to image individual neurons in the brain of behaving mice, which allows you to ask questions about what neurons are doing when organisms are actually doing stuff. that you can't ask using other ways. And Alex's research program is a beautiful synthesis, I think, of technical sophistication, like he builds his own microscopes, which blows me away, and computational analytic sophistication and neurobiological sophistication, asking cutting-edge important questions. That's a rare combination. And I think you'll see that that combination in Alex is recapitulated in his trainees. He's been a very popular place for trainees, grad students, and others. And we'll hear from one of them in just a moment. But first, Alex.
So it's a pleasure to introduce Al. So Al received his bachelor's degree from Berkeley and then an MD PhD from University of California in San Diego. He came to Yale in 2014. He was to do his residency. So he was part of the neuroscience research training program. And then after completing his residency, he stayed on now and is currently a research fellow at the VA. So, I mean, he has been extremely productive in both in the lab and in the clinic in his time here. A long list of awards, I'll mention a couple. He was named the NIMH Outstanding Resident. And then actually, the very last year, he also received a NASA Young Investigator Award. Al's research focus is on PTSD. So I think what impressed me is, as a mentor, Al was very easy to have in the lab because he's extremely independent. He would just go do his work, I think he studied the PTSD also in a unique way, using a very powerful approach that's more like a two-pronged method. On one hand, he uses experiments where he used mouse models and then he tried to characterize neuroactivity, control neuroactivity, to see how brain activity changes as a function of exposure to traumatic stress. And then on the other hand, leveraging some of his quantitative training in the PhD, he also develops a computational model that can explain some of the behavioral characteristics of the disorder. So I think he's going to talk a bit more about the second part today and maybe a bit also in the experiment. So so I think it's been a real great pleasure to have to work with Al, and I think you'll enjoy his talk quite a lot. So please join me in welcoming Al.
So Alex, thank you for that generous introduction, and thank you to the Lustman family for allowing me to share in this award this year. So today I'm going to talk about a computational model of PTSD that we've put together that we think characterizes some less looked at aspects of the disorder. And this work, many of the co-authors, John Crystal, Alex, are here in the audience, and it's great to see also many of my mentors and collaborators over many years here. So I want to tell you first about what the current model of PTSD is, because PTSD is a little bit unusual among psychiatric disorders in that we actually do have, in a sense, a kind of computational model that underlines a lot of our thinking. Then I'll kind of take you through the model that we're proposing, and then briefly about the future directions, looking at the neurobiological correlates of that. So before I can tell you what the model is, I have to tell you what is a computational model. So at the sort of dawn of the field of computational neuroscience, David Marr put forward this idea that you can't really build a computational model of a neural process by just looking at the neurons themselves. You have to look across multiple levels at the purpose of the neurobiological process. So if you're looking at a bird, you can't just look at how the feathers work in great detail. You have to say kind of what's the point of the feathers? What function are they serving for the organism, and model that. And then you have to say kind of algorithmically, like what process does the animal use to achieve flight? And then finally you get down to the feathers. And so in this talk, I'm mainly going to talk about those top two levels as we try to compose a model of PTSD that captures the kind of goal of the computations that we think underlie some of the changes in the disorder. And especially, this is a kind of different way of thinking about psychiatric disorders from just a simple pathological model. Instead, we're thinking about them as kind of extreme adaptations to circumstances. So you have these survival circuits in the brain, and if they're taken to an extreme, you may end up perturbing neural circuits in such a way that it leads to something that's very distressing and possibly dysfunctional for the individual. So to take you through the current computational model of PTSD. So this is based on really a lot of work that began here at Yale in the psychology department with Robert Rescorla and Alan Wagner back in the 1970s. So imagine that an individual is in an environment, a blue environment here, A, and they haven't been exposed to any threats. Then they'll go and experience some traumatic events in that environment. So their model says that you'll have a kind of prediction error. They thought that there was no threat in this environment, and then something really bad happened, which produced this prediction error. Then as time goes on, if they're in that environment, their brain is kind of predicting that more threats should happen to them, but nothing's happening, so it's kind of going down. Now they move to another environment, and they're no longer really learning anything about the old environment. So if you're treating someone who has PTSD, what you do is you re-expose them to the original environment, because being in that environment or going through a psychotherapy and hearing about the cues and associations involved in the initial trauma without having anything bad happen will induce a kind of negative threat prediction error that will cause them to adjust their perceptions of how threatening those initial cues were. So that's basically how it works. But when does that become PTSD? So this is a normal process that all of us have developed fears to various associations. And I think that underlying this, there's an idea that if the threat prediction errors, if the threat associated with the environment is sufficiently bad, you kind of have a threshold of how bad that is. And if it exceeds that threshold, then you develop some other things like nightmares, flashbacks, you begin to avoid the initial environment, and so on. And so that's a powerful model, and it's partly powerful because it satisfies Marr's criteria. So we know what the goal is. The goal is that based on your condition associations, you want to predict the threats that are going to occur in your environment in the future. So it's clear what the value of that is. And then at the algorithmic level, we have an equation, which we can fit to behavioral data from both humans and animal models, and we can then really characterize in a very quantitative and rigorous way what kinds of learning is happening. And I think it's fair to say that this model underlies a lot of our psychotherapies for PTSD, especially those based on exposure therapy, which essentially, in a sense, involve putting the individual back in that environment, at least to some extent, in order to create those negative threat prediction errors. And then finally, since we've had this beautiful model, we've been able to do neurobiological studies in animals and really break apart how fear associations are formed in the amygdala and how extinction memories are formed in the kind of prefrontal cortex to amygdala circuits. So this has been a very successful paradigm. So beginning with Rescorla and Wagner in the 1970s, the next few decades let us really build up a tremendous understanding of how fear associations are built. But there are some problems with the model. So most obviously, if an individual goes from in one environment, the blue environment here, and experiences a traumatic event, they generate a threat prediction error. Then they go to the red environment, and they generate another threat prediction error. And the association of the two environments is basically the same. There's no kind of synergy between these two different events. And yet we know from epidemiological studies of PTSD that there's a kind of cumulative loading of traumatic events in how they affect people. So this is some very elegant work from Carrie Ressler in the Grady Trauma Project in Atlanta, where they looked at a very impoverished neighborhood of Atlanta where people were coming to primary care clinics. And they basically just counted up how many traumatic events these people had had and then how many PTSD symptoms they had. And what they found was that the burden of trauma was tremendous in this community, and that if you classify how many of them had PTSD, it was about 30 or 40%, similar to people who are coming back from combat in war. And if you look across any row or column of that table, what you'll see is that there's a kind of linear progression of these PTSD symptoms in these individuals who were not seeking psychiatric care, but were simply burdened with various traumatic events in their lives. So since the reinforcement learning model doesn't really speak to this problem, we wanted to investigate this further. So first, we're going to say, how would a kind of optimal agent go about estimating the trauma rate based on the experiences that it has in the world? And then we're going to talk about the reinforcement learning model that kind of bridges the gap between the kind of classic Rescorla-Wagner kind of model and this kind of internal estimator of the trauma rate. So what is the goal? So you have an agent. This could be, a person who's going through the world, and they're going through the world in time. And at each time point, they can either experience or not experience a traumatic event. And that's defined by some probability. So if they've experienced an attack or a not attack, they develop a kind of life history of these events occurring or not that they can then use to update an internal estimate of those parameters that exist in the world on the right. And so the goal of the individual is to figure out how the world works. Do they live in a dangerous world, or do they live in a safe world? And what you see is that, as the individual goes through their life, they develop a better and better estimate with a thinner confidence interval of how dangerous the world is. But I want to emphasize that this is actually a very difficult problem. So an individual in this model will only experience a few of these traumatic events in their lifetime. So it's very different from similar models which are used to understand kind of reward behaviors. So in reward behaviors, you have a lot of data about, all the time about what's good in the world. Whereas with these traumatic events, because they could be lethal, the individual will only experience a few of them in their lifetime, even in the worst case scenario. And so based on this very sparse data set, they have to construct a very important model of the world for their survival. And actually the problem is even worse than that, because we know from data in animals that the level of these attacks is going to be fluctuating slowly in time with the amount of predators in the environment. And then if you look at human data about violence, there are also these very long correlations between the level of violence in the world over time. And you can also think about, for example, the kind of classic example of PTSD, an individual who goes to war and is suddenly in an environment where these violent attacks are quite frequent, and then they return home to an environment where they're not. And suddenly the adaptations that they've undergone to that environment are no longer functional for them. So what we find is that as the lighter blue is shown on the right, as we consider these attack rates fluctuating in time, and this individual still has these sparse data upon which they have to form this internal estimate of the world, they do poorer and poorer. So the more correlations there are along these slow, long timescales, the worse this kind of simple estimator will do at estimating the true attack rate in the world. And so this creates a need for us to develop a more sophisticated model that will keep track of the slow fluctuations of attacks in time. So now we'll turn to the algorithmic level to describe a kind of reinforcement learning model which we think can solve this problem to some extent. So I told you in the beginning that this is the classic reinforcement learning model of PTSD, and while it may work very well for the formation of fear memories, it has some clear holes with regard to the estimation of multiple attacks over time. It doesn't allow sharing of information about the overall nature of the world. And then we know from a lot of data in humans and also in animals that there are long fluctuations in how dangerous the world is. It's not something that's totally independent from one time point to the next. So the classic model is shown there at the bottom, where you have these prediction errors which are generated when there's a discrepancy between your experience of threat and your internal estimate of threat. So this model, which was put forward a few years ago in a very elegant paper that was trying to model bipolar disorder, they put forward this idea that you could share these prediction errors across all the different states that the individual was in. So if you imagine in this environment right now, if you were to undergo a kind of fearful experience, you'll have this strong association just to this environment. But the classical model would predict that when you go to lunch afterwards, you won't carry that with you. But what they proposed is that all of these prediction errors could kind of form like a kind of moving average of the history of unexpected threats or unexpected rewards in their case that the individual was going into. And so you kind of see that in the green here, where in an environment where the individual wasn't, there's a kind of momentum of threat that carries across all states. And we think that this can be reconciled with that epidemiological data about the burden of multiple traumas that we showed before. So in order to validate this study, we looked at behavioral data from mice. So the nice aspect of this behavior is that we can control the animal's behavior and induce a kind of threat momentum in them and see if it manifests as a kind of transfer to new environments. So on day one, in one environment, these animals will undergo a series of unpredictable foot shocks, and they will come back on day 6 to a completely different environment and get a mild foot shock, which doesn't normally produce a fear memory. And what we see is that if we come back on day 7 and see which ones developed a strong fear memory, the ones that had been pre-stressed, that is the ones that we think should develop momentum, have considerably more freezing on the final day, which is our readout of their internal estimate of threat. So we can go beyond that, and we can fit this model to that specific data instead of just looking at that endpoint, and we can really understand how the momentum is carrying across states according to this model. And if we compare mice that have been stressed, we see that this reinforcement learning momentum model performs much better than the classic reinforcement model at predicting the behavior of these animals. And the reason for that is that the classical model would not predict that the animals would have very much freezing on days 6 and 7 when they're in the new environment and just exposed to a mild stressor. However, in animals that are unstressed, we don't see that because there's no threat momentum that's developed through the behavioral manipulation that we do. And then if we turn then to this problem where the initial model that we presented failed, where the animal is trying to track a fluctuating attack rate in a changing world, we find that essentially the more momentum there is, the better the animal will do at matching those slow fluctuations, even in this information-poor environment. So the more fluctuations there are, the more information can be extracted by the animal with this momentum term. So in a sense, we think that this somewhat solves this problem of how do you extract as much information about these changing attacks that could be occurring in the world. So if we turn back to the question of PTSD, what are the implications of this model for the treatment of PTSD? On the left, you see the figure that I showed you at the beginning, showing the individual exposed to traumatic events in one environment and then undergoing psychotherapy, which are those sort of thin blue strips on the left. Now, and that's called extinction learning and underlies a lot of our psychological therapies for PTSD. But we're proposing here that maybe the PTSD symptoms don't come from the strength of the initial fear association. Instead, they come from this momentum term that shares threat across all the different states of the animal. So if you believe that, this offers a different explanation for why these psychological therapies work. So in addition to developing negative threat prediction errors that decrease the association to the initial context, they also reduce the momentum, which you can see on the right, through the same mechanism. So that's an alternative explanation for why these psychological therapies work. And then some other phenomenon that have been explained in different ways have a new explanation in this model as well. So it's known that people who undergo these kinds of exposure therapies will often relapse. The explanation that's given for that is that they've extinguished the memory and then it kind of renews itself over time. As the individual's in a kind of psychotherapy, that's one situation which doesn't completely get rid of the initial fear memory, and then it kind of comes back as they experience things in the world. We offer a different explanation, which is that the individual goes out and undergoes new stressful experiences, which increases their threat momentum, which both increases the threat momentum term and also increases the association to the initial event. And there's substantial epidemiological evidence as well for the idea that people who undergo, for example, a divorce will have more PTSD after a natural disaster. So they've done kind of retrospective studies like that. And this could explain that because the divorce, even though it has nothing to do with the actual natural disaster, induces a kind of momentum which is coupled then to the one that's induced by the natural disaster. This also, just as a final point, offers some potential new avenues for psychological therapies for PTSD. Because whereas in the classical model, the only way that we can reduce those threat prediction errors is by exposing the individual to the initial traumatic environment. In this model, anything that seems threatening but ultimately isn't would induce the same kind of changes in momentum. So this is a potentially new avenue for people to explore in psychotherapies for PTSD. And so just finally, I'll just outline for you how we're going to go about figuring out how the brain does this computation. So there's been a lot of research, especially here at Yale, that Steve Southwick, John Crystal, and many others have been involved in about the role of norepinephrine as a kind of arousal neuromodulatory chemical and its role in PTSD. And that there's an idea that it could be involved in kind of sensitizing increased emotional responses. So using new biosensors that have been developed to let us measure the neurochemical fluctuations of norepinephrine, we're able to actually do that as animals are exploring an environment and experiencing unpredicted threats. So we can determine whether the chemical fluctuations of norepinephrine in real time are increasing and representing those threat prediction errors. We can also, as was mentioned by Chris in his introduction to Alex's work, we can also record the activity of those neurons in real time and look for network activity patterns that may represent this threat momentum. And then finally, using some collaborations with some colleagues here in Ron Dumont and Nanette Seston's lab, we can record the RNA, we could do RNA sequencing on these norepinephrine neurons in the locus ceruleus and see whether we can find molecular pathways that may induce this threat momentum term. And the nice thing about the model in terms of informing all of these studies is that we now have a quantitative way to measure continuous changes in stress. Whereas classically people have just used stress as a kind of yes-no question in these mouse experiments, now we can measure exactly how much stress should the animal be experiencing at different points in time. And so with that, I just want to thank, first of all, the Lustman family for the generosity. Also my family, so these are my twins, my wife Jennifer, who's in the back, and my parents for all of their support. As Jenny said, it is a long training process. I know my wife is tired of hearing about all the decisions and that go into each stage of this process. Especially I want to, there's obviously too many people to thank who've kind of helped this work at many stages, but I want to emphasize in particular two individuals from Alex's lab who collected a lot of the data that I showed. So Geeta Rao is going to Mount Sinai for medical school, and then Gianna, who's a research associate, is applying for MD PhD programs and will be a Lustman 2030 winner. And then, all of my collaborators and people who've discussed this project at very early stages and helped me to develop it. So, and also, especially also Chris and Bob for all their support during the residency and afterwards. So with that, if there's any questions, I'd love to answer them.
So I'm curious as to whether constructs that people have thought about for resilience, in other words, flexibility,
Right.
behavioral flexibility, or capacity for reversal learning, whether these are part of the momentum term, or do you think they're part of the associative learning process?
That's an interesting idea. So I guess I would say that they would be either part of the momentum term or sequelae of changes in the momentum term. So for example, the prefrontal cortex can suppress the activity of the locus ceruleus, and that's a kind of active area that people are studying. So you could imagine that as the momentum accrues and you have these kind of arousal and other neuromodulatory systems that are carrying it, you're in a less prefrontally driven kind of network activity. Or conversely, that by activating the prefrontal cortex, by activating these more flexible patterns, you can suppress momentum itself. So that could be a potentially, in a more complex model that captured some of those cognitive aspects, maybe that could be a way to reduce momentum.
I know, so I see that there are other questions, but don't go away. Why does everyone do this?
We're scared at this.
So it's a pleasure to also present you with first place award in the Lustman Awards 2019. Congratulations on the great work and a great talk. All right, let's see if I can learn. Look at that. All right, so for our third and final talk this morning, it's a pleasure we'll hear from Kunmi Sobowale, and it's a pleasure to invite up his mentor, Dr. Megan Smith. Megan is an associate professor both in the Department of Psychiatry and in the Child Study Center, highlighting the close collaboration between the two sides of the street here. And her work focuses on the mother-child dyad interaction, consequences of mental health difficulties during pregnancy for long-term outcomes. But something that's particularly striking about her work is the engagement not of the laboratory studies, the clinical outcomes, but also the engagement with social stakeholders and connecting with different groups and looking at the effects of various sociological variables such as socioeconomic status and racial factors on these processes and these outcomes, which brings us a critical dimension to the research. So Megan, it's a pleasure to have you with us today, and if you'll come up and invite and introduce Kunmi, please.
Good morning. It's really an honor to introduce Kunmi Shobowale to all of you. Kunmi graduated from Yale University, where he received his undergraduate degree, and the University of Chicago Medical School. Kunmi had already done a substantial amount of clinical research before coming to us at Yale, really working at the area of his passion, which is the intersect between poverty, mental illness, and gender. And during his tenure at Yale, Kunmi has won numerous awards. I'll just highlight a few, which is the ACAP Travel Award, the APA SAMHSA Fellowship, the Yale Global Mental Health Award. Also, Kunmi has numerous publications that really span the population-level behavioral health impacts that he has already made in his career. So publications on neuroscience, behavioral economics, and global mental health. In addition to his domestic work, he's also worked globally in Japan, Mongolia, Vietnam. So it's just been an absolute joy to work with Kunmi, and I think, aside from his obviously, high intellect and the rigor that he brings to his research, what really stands out is Kunmi's integrity, and I think many of those in my lab will comment on the kindness that Kunmi brings, the compassion that Kunmi brings to his work in the research setting, but also clinically, and I think also importantly, Kunmi's collaborative spirit, and so I think that really gets us far in the field when we think about team science and where we need to move. Kunmi's often pulling in partners and researchers in different disciplines into the work, and I'm always so appreciative of that. And I was looking back to the first email that Kunmi ever sent me in his first year of residency, and it really characterizes every email you have with Kunmi thereafter, which is after every meeting, it's typical that Kunmi sends a PowerPoint presentation with maybe 5 to 6 slides summarizing the meeting, talking about future directions, but then also we'll send along 2 to 3 articles that have appeared in the journals that week. And not only send the articles, but synthesize them and provide a summary of how that's relevant to the projects we're doing. So, I've been spoiled by Kunmi. So I will miss that. I'm saddened that Kunmi is leaving us, but I'm also really heartened that he'll be doing work on population-level behavioral health in the Department of Psychiatry at UCLA. So I think undoubtedly Kunmi will be a leader in the field and also really make a difference not only in the lives of individuals, but also on a population level. So please join me in welcoming Kunmi.
Thanks for those kind words, Megan, and thanks everyone for coming out today, and the Lustman family for giving us this forum to share our work. Often our work ends up in journals that, may be read by a select group of people, hopefully. So having the opportunity to present to you guys is really an honor. So today I'm going to talk about the impact of cash transfers on the well-being of children with special health care needs as well as their families. So maybe you guys saw the New York Times this week. They had an article titled "A Secret to Better Healthcare," where the authors posit that investment in social services such as housing or food stamps is the secret to improving healthcare in the United States. And while I agree with their sentiments, it's not so much of a secret. Social determinants of health has been talked about by Kaiser. It's been talked about by the New England Journal of Medicine. It's been talked about the National Academy of Medicine. And it's been talked about by the CDC. So this is not something new to focus on social determinants of health, but the healthcare system having a role in providing social services and benefits is something that is novel. And there's a good argument for this, because if we look at the impact on morbidity and mortality of populations in the United States, a lot of what accounts for their health is socioeconomic and behavioral factors. The things we do in the medical setting have generously 20% effect on these outcomes. And most studies actually say 10 to 15%. So if we think about social determinants of health, we can think about poverty in relation to mental health. And poverty is important because it relates to a lot of social determinants of of mental health. And one of the leading theories in how poverty is associated with mental health is the social causation model, which basically says that the conditions of poverty, such as adverse environmental events, material hardship, and the stressors that come with that material hardship are things that can worsen mental health. And this is particularly the case for families with children with special health care needs. And this is a population of children who have physical as well as psychiatric chronic illness that leads to higher utilization of medical services. And this population has high rates of mental illness, the children as well as the parents. So national surveys find about 50% or more of these children as well as their parents endure significant depressive symptoms. And when you ask these families in qualitative and quantitative work, what are some of the stress in their life, finances often come up. And for the parents, for example, this takes the form of multiple things. So there's the routine costs of raising a child, which can be higher in this population as their disease evolves. There's a healthcare related cost that this population suffers. And then there's a loss of economic productivity for the parents of these populations. They often have to drop out of the workforce or cut down on work hours, and this means that their ability to support their families monetarily can be challenging. So what do we know about giving social services and things like cash and its effects on mental health in the US context? The best studied cash transfer program is the Earned Income Tax Credit, EITC. It's a lump sum of money given to low-income working families in the US. And even though there's not a ton of studies in relation to mental health, you find that it has been shown to decrease maternal depressive symptoms. You also have programs like TANF or SNAP, colloquially known as welfare and food stamps. And these programs, their eligibility and the amount of money they give vary by state, which makes them harder to study. And you also don't have a lot of longitudinal studies with these programs. In fact, TANF has been found in some studies to have beneficial effects and some studies to actually worsen mental health. There was a randomized controlled trial in New York of children and their families where they provided these families money if they met certain conditions. So for example, if the child attended school for more than 90% of the days of the year, they would get a cash allowance. And this also found mixed effects. So it decreased child externalizing behaviors, but had no effect on depression or anxiety in these families. So the question we had is, if you had an ideal kind of system of collaborative care, where we were helping address some of the medical and social needs of this population, what is the added benefit of monetary assistance in these children and their families? And I should say I did this work, of course, with my mentor, Megan, with Ashley Clayton in the Moms Lab, and Maria Claire Largo in the School of Public Health. So one potential, very simple theory of change is that the chronic illness affects all these aspects of these families' lives. And perhaps by providing some monetary assistance, like flex funds, we can decrease their financial hardship, which would potentially lead to a decrease in their parents' stress and depression. And perhaps this can increase their self-efficacy to take care of their child's health and thereby lead to decreased mental health issues in this population. And we got a great opportunity to study this in a program called Wraparound New Haven. This was a Center of Medicare and Medicaid Innovation Grant, which allowed us to study an innovative collaborative care model where a care coordinator helped bring together mental health providers as well as the physical health providers, primary care doctors essentially, together on a treatment plan that was aligned with the family's goals and also to have those two sides of their treatment collaborate with each other. And with that too, there could be social supports like making sure these children had an individualized education plan and so forth. To be eligible for this pilot, these families had to be on Medicaid, so a low-income population. These children had to have a chronic physical illness and either a mental illness or a condition associated with mental illness. So things could range from asthma to things like cerebral palsy. There was really a lot of variability. And these children had had 2 ED visits or 1 inpatient hospitalization within the past year. And what was really cool about this study is the provision of flex funds. These are disposable income that these families could use for a variety of things. They could use it for education, they use it for childcare, pretty much whatever, as long as that resource already wasn't in the community. So we looked at measures of depression and patient activation. For depression in children, you look at the adapted CSD. For parents, you looked at PHQ-9. And this measure of patient activation is really one's knowledge to take care of their chronic illness and also to manage that. And we looked at parents' ability to manage their child's medical illness as well as their own potential medical illnesses. So we wrote ultimately had 325 children and their families in this project, 254 of which received flex funds and 71 which did not. On average, these kids are about 9 years old, mostly boys, or a little bit of majority boys, racially and ethnically diverse. Kids were in the program for about 10 months, and 52.4% had significant depressive symptoms among these children. Patient activation, which is out of 100, was pretty high at baseline in terms of these parents feeling like they could manage their children's medical illness. And now if we turn to the caregivers, we see that the average age is about 40. Vast majority are women caregivers, also racially and ethnically diverse. 58.2% have a high school education or less. I should say about 38% of these women were working for money, which means that vast majority of these women are likely not receiving some of the work-related social services like the earned income tax credit and so on. That would be helpful for poverty alleviation. And less than 50% were also married or in a significant partner relationship, which also puts a lot of pressure on these caregivers. So in terms of funding, so families received on average about 2 checks, and kind of the median amount of money they received was $780. And how was this money actually used? So we can see here that it was spent on things like bills, clothing, and furnishing. And this aligns with the literature that you find from the earned income tax credit, that people used money to get out of debt to pay bills, so for poverty alleviation and social mobility. And then they used it as well to help with things that are more rewarding, so providing for their children. So clothing was the biggest category here, and often that was school uniforms. School uniforms, kids grow, and it's actually very costly. So that was one of the things. And then furnishings for their own house. And then it's not surprising to see things like transportation, the cost of maintaining a car, particularly for these families who are trying to make ends meet, can lead to unexpected costs. So that was another big area. So in terms of our main questions, what was the effect of receiving money versus not on children and parents' depression and patient activation? So we didn't find any effect for the additional effect, I should say, for receiving the flex funds for children's depression or for parents' depression or the parents' perception of managing their own or their child's health. And so if we ask, does the amount of money matter? And so we find it does matter, but just for parents. So in this case, parents' depressive symptoms decreased by, on the PHQ by 0.13 for every extra $100 that they received. And then similarly for patient activation, for every extra $100 they received, their patient activation went up by 0.6. So if we go back to this model and think about children with special healthcare needs, we can say, provision of monetary assistance helped with certain things like decrease in economic hardship. We can see what they spent. We can see that if you give sufficient money, it's possible that you can decrease parental psychological distress. But we didn't see the effects on caregiving. And it's also possible, of course, that this chronic illness that these children have that even with these economic supports, it's not sufficient to move the needle. And so just to conclude, money alone wasn't sufficient for these children with special health care needs in terms of improving their depressive symptoms. But I really think it's important to think of the structure of the cash transfer. I mean, how frequently you provide it, the amount we saw was important, at least for parents, and also things like, should it be conditional or should it not be conditional? So this was the first study to look at a cash transfer in this population and in their parents. And it's promising in that maybe cash could move the needle for their parents, but perhaps we need something more to move it for their children. And in terms of future work that's exciting, we can ask the question, you know, if this money went to perhaps to the aspects that might benefit the children more directly, would it have more of an impact? So the lab, under lead of Ashley and Megan's now doing a randomized controlled trial of providing diapers versus cash assistance in the postnatal period to see its effects on mental health, healthcare utilization for mothers and or parents and their children. So these are my references, and I wanted to first, again, thank the Lustman family for providing us this forum and being able to be part of this long tradition. I wanted to also, that reminds me to thank my family, particularly my wife, who's in the audience, for all of the sacrifices that she's provided over the years to help support my work. And I also want to thank my mentor, Megan, for all her great support, as well as Ashley, who's been a pleasure to work with over these years. And then just the Moms Partnership staff for all their important work that they do, and really glad to be part of that group. And then finally, just the funders who allowed me to do this work over these years. So, thank you. Yeah, in terms of a mediation model, so the intervention as a whole, so in the intervention as a whole, depressive symptoms, decrease in patient activation, increase for both children and parents. But financially, we didn't find that effect. And we didn't look at it in a mediation model, but that's something we can do moving forward.
Kunmi, thank you for a great talk, and congratulations to you. It's my pleasure to present you the second place award, the Lustman Award of 2019. Well, thank you all for coming. Thanks to the presenters, three wonderful presentations on, as I said at the beginning, very contrasting, equally important and exciting areas in our field, and to their mentors for your support over the years and for being with us today. We'll see you all next year.